What's up, everyone? So we'll give people a few minutes, or maybe a couple minutes, as all you guys roll in. We're gonna have a packed house tonight, I think. Hi, Megan.
Hello.
If you happen to see the authors pop in,
Gotcha.
I'll just ask them if they want to be inundated with questions right off the bat.
Sweet.
Actually, I think I see the lead author coming in right now.
So the reason why we did this study, our group was running a prevention trial, an exercise and education prevention trial here in Sydney, but we were having quite a lot of issues with the patient recruitment and people's acceptability of the exercise program. Some people dropping out of the study because they were telling us they didn't have time enough to commit to the exercise program and things, and this was a comprehensive exercise program, lots of sessions, lots of one-on-one contact with the physio, in addition to some group exercise classes as well. So that got us thinking if people would actually be willing to undertake a more comprehensive exercise program, which we believe and which evidence shows actually that's what needs to be done in order to prevent back pain. So this was kind of the starting point, and then we were just thinking of ways of doing this study and conduct this sort of experiment. We thought of doing a normal survey and just ask people, would you do an exercise if it had ask characteristics X, Y, and Z, yes or no, and then just go from there. But we got in contact with some health economists which work with us, and they advise us to do this Discrete Choice Experiment thing, which is a nightmare of a study designed to explain. And I hope some of you will eventually jump in and help me with that when presenting the paper. But basically, we gave people lots of different scenarios with varying characteristics of exercise programs, including whether the program would be supervised or not, whether it would be in group or individual, the cost, the effect of the program, the setting in which the program was going to happen, and they had to choose whether they would be willing to undertake that program or not. And what we found in our sample of people, which was a representative sample of the Australian population, was that yes, people were generally keen to do exercise and to choose doing exercise programs to prevent back pain over not choosing exercise, and I think that's a good news from the study. But then when we analyzed the individual components of the exercise programs, people didn't seem to be as keen to go for longer duration programs, and they preferred cheap programs. And we know that there's lots of issues with funding for these programs, especially here in Australia. These are not funded, so they would have to be covered out of pocket, and they're likely to be a bit more expensive. And so people weren't keen to do what we believe needed to be done in order to prevent back pain. So that's a very brief summary of what we did and what we found.
Thank you so much for that. And yeah, there's a lot to dig in because this paper was really interesting and it seemed like a lot of work, which is, work on the front end. Then we get to have these fun conversations. But just some quick logistical notes for people. So feel free to use the chat, ask questions in the chat, and we can read those off. You can unmute yourself. I think you'll have a digital hand icon where you can raise your hand and you can unmute yourself, and you can join the conversation as well. Really, you can do that at any time if you want to. You could, in the chat, put question in all caps, and then we'll read off your question, or if you mention in the chat that you have something to say out loud, then we'll call on you. We are going to do breakout rooms at the end. And so people get to make friends and see each other's smiling faces. We get to talk about this a little bit more. So that'll be a lot of fun. If you didn't get a chance to actually read the paper, I'm going to throw up the link. It is open access. So this is a link to the journal, and then you can just press download, and you can get the paper and you can pull it up, and so you can be talking along or reading the paper, looking at it along with us. And then, so just to introduce myself, my name is Quinn Hennick, and I'm a clinical athlete provider, and we lead these things with my partner in crime, Kevin McNamara, who's in the crowd now. He's a physical therapist in the Seattle area, and he's really the one that's responsible for bringing these journal clubs to life. So what's up, Kevin? Are you there?
I'm here. Not much.
Awesome.
Gonna be a spicy one tonight. We got a lot of people. Thanks for you to the authors, by the way, for coming on. That's great. So
yeah, this is a nice treat. So people don't have to listen to Kevin and I just mindlessly babble and probably get it wrong. So you guys can correct us. It's super exciting. And remember our journal club motto, in the spirit of Benjamin Franklin and the Junto Club that he started as a mutual improvement club long ago. These meetings are conducted in the sincere spirit of inquiry after truth, without fondness of dispute or desire of victory. So we're all on the same team. We're just out here trying to be less wrong. So the paper, if you've pulled it up, is titled "People Considering Exercise to Prevent Low Back Pain Recurrence Prefer Exercise Programs That Differ from Programs Known to Be Effective, a Discrete Choice Experiment." And we have the lead author, Giovanni, and one of the authors on the list there, Joshua Zadro, on the call. And Giovanni went through a really nice rundown and kind of the impetus for the paper. Now, the results are interesting. So first of all, I wanted to ask and make sure I have this right. You gave a brief kind of education on low back pain to all the participants before you gave them their 10-question card. Is that correct?
Yeah. So everyone in the sample either had back pain at the time of the survey, or they had a history of back pain, had back pain at some point. But yeah, we gave them a very small blurb just describing, the burden of back pain in Australia, the prevalence, and how much recurrence is common, before we introduced them to the survey.
Was there any concern with some type of bias there doing that before they were questioned, or what was the impetus to do that?
This is common practice in discrete choice experiments. You have to kind of give people a bit of a lay of the land and make them understand what we want with the study. I think I get your point, and we try to be as transparent and as guided by evidence as possible. So we simply put, what's the prevalence of back pain, just to highlight it's common, but these people already had back pain at some point. And we showed that them the best information that we know about how effective exercise is. And we thought this could be a good way of framing the question without leading them into wanting to do exercise. But we thought of giving them the information as the evidence shows right now.
And the actual questions themselves, I know that in figure 1 on page 3 of the paper, I've got it pulled up now, that was from my understanding, this was from the pilot study, but they looked, the question sets looked pretty similar to figure 1. Is that correct?
Yeah, that's it. So figure 1 is actually one of the choice scenarios, and people were shown 10 of those, and each one of those scenarios had different things written in them in terms of the attributes and how we were describing them.
And you guys included some of the subsets of the attributes in the appendix, so you can download those online too. The link that I sent, you can download to see the levels of the attributes. So all the participants got all 10 cards.
They got 10 cards. They didn't get all the cards because there's lots of attributes and different levels within each attribute, which would make it impossible for people to go through them all. So we had a combination of, we had a list of, can't remember how many, maybe 60, and then we randomized people to each 2 blocks of 10 choice tasks.
Got it. Kevin, do you have any questions methodologically or anything like that?
No, I don't think so. I thought it was really well done. It seemed like you mentioned this is kind of like my first exposure in terms of the study design with some of these. So it was a pretty good learning experience to me, just looking at kind of like the logic and just the general setup of it. So I don't have much to add.
Guys, when did you weigh different study design options? What ultimately made you go this route? Was it perhaps just kind of the ease of doing some type of qualitative or subjective quantitative study that way, where you can get a big sample versus an alternative?
Yeah, I think this was one of the issues. And I think the biggest probably advantage of this study design is that we can, unlike other survey designs we could with the discrete choice experiment, we could understand people's trade-offs. So if we gave people just some questions, would you prefer group or individual exercise? And then the person would tick which one they preferred. We wouldn't be able to know whether the person preferred group exercise, for example, in relation to every other attribute that we had, in relation to cost, in relation to travel time, in relation to a possible effect size that the person would get out of that program. And we were able to do that with this study design. We were able to understand the trade-offs.
Can you go into, actually, I'm gonna launch a poll because I just found the analysis was fascinating and there were so many layers to it. But I'm gonna launch a poll. I'm curious to see what type of demographic we have here with us. So we've got 63 people on the call. I just launched a poll. It should pop up in front of you. And it's just asking, are you a clinician, student clinician, coach trainer, or student coach trainer? I think it's up. Start answering, people. Are you paying attention? Should be right in front of your face. I have 0 voted. Do you guys see the poll?
Yeah, it's up.
Is it okay? Maybe interesting. Well, I guess you can just answer to yourself of who you are, because that's what I see right there. 0% of all of that. Okay, well, that was a flop. Well, we usually have like 50%.
It has the results there now. We can see it on the Zoom.
Oh, really? Oh, it's like I'm the only one who can't see the
55% of
results.
clinicians.
Thanks.
Yeah.
Appreciate it. The hell, Zoom. 55% clinicians, sweet. And then probably student clinicians make up the
40%.
second cohort. Yeah. Awesome. It was probably why we have such a big turnout, because this is super relevant. So in general, this cohort that you guys looked at who had experienced or were experiencing low back pain or had experienced low back pain in the past 12 months, in general, were more likely to choose exercise compared to no exercise when the exercise programs were held at home in general, rather than say a gym, had a shorter duration on average, shorter travel time, offered higher reductions in the risk of low back pain, kind of incrementally, and were low cost. So all of those things make sense. I want to dig into the reductions in the risk of recurrence a little bit. Do you guys think, so the body of evidence that we have, and you guys mentioned this in the paper, that in general, the studies looking at prevention of recurrence of low back pain, the exercise protocols are pretty intensive. And that was one of the questions, would people adhere to that? And it looks like people prefer shorter duration or less intensive exercise programs. But potentially, do you guys think that maybe that's just a paucity in the evidence now? Have there been, and I'm not familiar with that body of research as you guys linked, so maybe I need to do some digging, but have there been papers comparing protocols in which the less intensive protocol is less effective? Or is that just something that's not been studied yet?
think where we got that from is the most recent systematic review on the prevention of back pain. And so it includes a number of trials. Giovanni can give me the exact number, but what we did was look at the characteristics of the trials that showed beneficial effects. And so when you look at those, it seemed to be that the ones that were more intensive, went for longer, had more sessions a week, were the ones that were showing effects, whereas those ones that were of shorter duration, had less sessions, were the ones not demonstrating effects. And so that's where we kind of extrapolated to say that people in this study seem to prefer those less intensive programs that require less commitment, but that's not really what the evidence is showing are the most beneficial ones. And I guess that's reflected in Giovanni's trial that he's leading, where they've taken a number of years to recruit an adequate number of participants to the trial, just because the people out there probably don't care enough about reducing the risk of recurrence of back pain, depending on how intense the program is. So, and I think also if you look at the risk of recurrence, 30% experience back pain in the next year. I wonder if giving patients that background before they started the survey kind of made them think, well, unless the program's very short duration, I'd rather take my chances because you know, only 3 in 10 will get back pain in the next year. So maybe they like their odds.
Can I just jump in and give some more information on that? This was a bit of a bugger, and we had finished collecting the data. We were actually writing up the paper when a new cohort study just came out with and showing a very different recurrence estimate for back pain. So it came out, I think, in Journal of Physiotherapy as well, and it showed that about 70% of people had a recurrence within 1 year, so more than double. And that was a bit of a problem for us because, you know, we had already collected all the data and we had given people that 30% number. And like Josh said, maybe that could have changed things a little bit from the person's perspective if they knew that their chances of having a recurrence was bigger than 30%, but we don't know that.
Well, and then potentially you would call the author group that did the original systematic review, and hey, say maybe you still have your data. Can you do a sensitivity analysis on this new paper that just came out and see if it would really skew that? Because that, you know, you wouldn't want to necessarily change your tune on any one paper anyway. And I haven't looked at that one, but that's interesting. It always just seems to work out like that. You finish a new project, you think you've done a thorough lit review, and then bam, have you seen this paper? No, damn it. Glad to hear that you guys run into that problem too, but that's really interesting. Can you explain the latent class analysis? So we've got this general avatar of a person, these general attributes. People seem to prefer low cost, low travel, do shorter duration exercise programs at home. But then you broke them down into these subclasses with different attributes of or characteristics of the person. Can you talk a little bit about that analysis and what that tells us?
Sure. So just simply put, latent class analysis is a way of simplifying complex populations into more homogeneous groups. And that's what we wanted to do with this analysis, because when we ran the main analysis, we found quite a bit of variability in the responses, and we discussed that in the paper, and we used that information to decide, to do this latent class analysis, because we wanted to find whether there were subgroups of people that would have different preferences. For example, if they would prefer exercise more or less, or among those that did prefer exercise, if they would have different preferences for components of the exercise programs. And so basically this is what the analysis is about. It's just finding subgroups of people. And let me just put something on the chat here. This is an an interesting paper that recently came out in JAMA. It's for clinicians, and it's got a nice language, and it explains a bit about latent class analysis. So if you guys are interested in it, have a look. Yeah, is there anything else you would like me to add, Quinn?
No, that makes sense. Is it the model itself that's extracting the different classes? So we had our base level class that was class 4, then we had class 1, 2, 3, and is the model kind of pulling those attributes and creating those subsets itself, or do you have a hand in that?
No. It's only the model. This is, at least for this study, I can't speak for what happens in all latent class analysis things, but for this particular study, it was a data-driven sort of model. And I guess if we were to be very picky, and I guess we would need to try to do more research and understand whether those subgroups that actually exist outside of my data set. Do you know what I mean? And this is, I think, quite common in this subgroup sort of literature. People come up with this data-driven groups, and they may not particularly be representative of the population, the behavior of the population, and that's why we didn't talk too much about them in the discussion and in the paper as well, because they were a secondary analysis, and there are some more issues that I think are important to do before we say, well, there is a subgroup of people like we found, that middle-aged men on lower incomes have strong negative preferences about exercise. They're not willing to exercise. And I guess this gives us a good starting point to actually go and study that population and see what they actually think about exercise, and whether we need to approach them differently to make them buy into these sorts of programs. But I would be a little bit cautious in making lots of extrapolations about this analysis in particular.
So
Giovanni, would it be right to say that the latent class analysis identifies groups of people who tend to make the same choices? So it identifies a cluster of people who seem to choose similar things, have the same pattern of choices?
Yeah. So for us, we grouped people into those who had a similar, what we call preference structure, who preferred similar things. And then from that analysis, we were able to see what personal characteristics were predicting those choices, like age, income, sex. We tested some other variables, whether the person lived in metropolitan versus rural areas and stuff like that, and we didn't find a difference. But yeah.
Cool. Okay, so we've got some questions here, and I think the people who are typing their question with the capital question are people who were willing to unmute themselves. So I'll go with Taylor first, and if I'm wrong, I'll just sit here in silence and then read the question. Taylor, do you want to unmute yourself? Okay.
Yeah,
Hi.
I don't mind. Okay. So when talking about the study that came later on that showed 70% recurrence in that year or so time frame, did you find that the population studied there was pretty similar to the group that found 30% recurrence, or could that difference be explained by just different demographics?
Yeah, I don't know the answer for that. That was a different study design. So they followed up people for over a year, people who had back pain. Yeah, I wouldn't be able to tell you that. We tried to have a representative sample of the Australian population. I don't know if their study had the same characteristic. Those were people seeking care. Our sample didn't involve everyone that had sought care in the past. So there were people there who had never seen a health professional. So I guess there could be some differences in the groups. Yeah.
But both were Australian?
Yeah,
Okay.
Both here in Australia. Yeah.
To kind of piggyback off that same exact question, because you just mentioned, do you find that might be a difference because there's a difference between like the studies that you guys cited for like the very intensive 20 visits or whatever over 13 weeks, those looked at pain as the recurrence and not so much seeking care, if that kind of makes sense. And then the new study with the compost that came out last year, and Chris Maurer was on it, that did like the McKenzie versus just a phone call, that one didn't find that doing just two sessions of McKenzie was enough to lower pain, but it did significantly lower care seeking behavior. So do you think that there's a bit of difference there
in how we define recurrence?
Right.
Yeah,
And,
maybe.
And so that might change, like, because the ones that you cited that said that the best evidence for lowering recurrence were intensive, but the McKenzie study was only two sessions, and that lowered, care seeking, which is probably what we care more about, more than just, hey, I had 3 out of 10 pain that day.
Yeah, I guess there could be. This is, I think, a big issue in the prevention research right now, finding ways to better define recurrence and what's actually meaningful to people. And I don't think we have the answer for that yet, whether it's pain, care seeking, or not being off work for a day or more, for example. There's lots of questions around there. And yeah, I guess that could make a difference in terms of what studies found and what they reported. Let me just say for the McKenzie trial that came out, they didn't find a significant difference in reduction of care seeking. They found their estimate was very imprecise, but the point estimate was very low, which could have shown, which was indicative of a preventive effect. But if you look at p-values, that there wasn't a significant difference, but maybe because there was too much imprecision, they would have needed a much bigger sample size to have actually found a significant difference. But they hinted, that it could have been good for reducing care seeking in the trial.
We see the same problems with studies looking at preventative measures for injury as well. Definition of injury, contact, non-contact, time loss, those types of things. So I think at minimum, if you're trying to extrapolate inferences from these studies, you need to look from study to study. It's likely that you're going to see different definitions. And so you have to exercise caution when you're trying to make then general inferences, outside of a particular study. But that's a really good conversation point from you guys. Thank you. Michael asks, is there a typical length of time defined for a recurrence? I think you guys, it was with the paper that you cited, it was just a recurrence within the next 12 months. Is that correct?
Yep, very simple.
There wasn't any, are you aware of any data where if you are going to have a recurrence, it's within the first 6 months, 75% chance of within the first 6 months, and then something like that? Or you see any weighted probabilities that way?
Yeah, like I said, this new cohort study came out at the end of last year, and it showed that within 12 months, about 70% of people will have a recurrence. And I think that number is a little bit lower for 6 months and 3 months. So I can put the link on the chat.
Yeah, that would be great. Because now we're all wanting to read about this study that almost ruined everyone's lives. Samantha asks, Samantha, do you want to unmute yourself? Samantha W. I'll sit here in silence for 5 seconds and allow you to do that. Okay, I'll read it. Short duration equals how long? So short duration of exercise, the exercise sessions equals how long? And by comparison to an average length of ? Is this in the appendix, these levels of exercise duration? So she's basically asking, what is considered a short duration of exercise versus long or average?
Yeah, so I think the durations, Giovanni, correct me if I'm wrong, were 1 month, 3 months, 6 and 12. And so then the results in table 2 would represent a jump from one of those categories to the other. So we didn't have all the possibilities, but as you move to one category to the next. Oh no, so you've said that per extra month, you've been able to model, Giovanni, for the program.
Yeah, and what that result shows is that for every 1 month increase in the duration of the program, people were less likely to prefer exercise.
Mm.
Can we say 8% less likely, or?
Yeah, that odds ratio isn't actually interpretable, just less likely.
And does that also apply to the risk of recurrence of low back pain? So increases a 10% reduction in risk. All you can say is you are more likely to choose an exercise program, but the odds ratio is not a multiple of that.
That's right. Yeah.
And Samantha, just in case, that's the duration of the program as a whole, not each exercise session bout. So just to make sure that was clear, because that's not what they looked at. Samuel asks, I'll give the 3 seconds this time, because that 5 seconds of silence was painful. Let's get 3 seconds of silence for Samuel to unmute himself and ask his question. Okay. Was there a preference that was relatively consistent throughout all of the latent groups?
No, not really. Not really. We found that 2 of the latent groups preferred exercise, but 1 of them didn't. And that was the group that had very strong preferences against exercise, so to say. But no, we couldn't find anything that stood out, and that was very consistent across them all.
And that latent group was older, had lower socioeconomic status, lower levels of self-efficacy, and for that group, cost and the effectiveness of the program didn't matter, which you guys mentioned. This potentially suggests that for certain subgroups, the barriers to choosing exercise go beyond the effectiveness of the program, or their perception of the effectiveness of the program, and financial costs. So you might be looking at things like age and socioeconomic status is interesting, because you would think that would be linked to cost, but maybe there's some other type of moderator there. Geronimo, did you type that question after you already talked? Because why don't you just ask it? Fine, I'll talk for you. Did you guys describe what the exercise would look like? Or the exercise program? Geronimo, is there a word missing there?
Yeah, I guess we described it as much as the attributes would have described it. So in terms of how it was delivered, group versus individual, supervised, whether it was at a gym or physio clinic. But I don't think we gave any examples of the exercises that we did, or, specific details.
Okay, so that would be interesting as well. Do people have certain preferences for the modality of the exercise with this type of the same model that you guys ran?
Giovanni, the systematic review on trials of prevention, is there variation in the exercise programs there, or is it a lot of it specific back strengthening?
No, there's not a lot of variation. There's I think there's a lot of trials that do a very comprehensive exercise program, and they've got, strengthening component, flexibility, aerobic, multi-component exercise. There's a few trials with more simple approaches. So there's one trial in the military where they asked people to do back extensions, how many times a day for God knows how long, 10 months, I think. And but yeah, there's not a lot of variation. The reason why we didn't ask people about specific questions about the exercise modalities is that because a different study had already done that, and it's I've just popped it in the chat as well for you to have a look. So it's a similar concept, a discrete choice experiment, but if you look at the study, they were interested in knowing what people preferred in terms of the exercise modalities, and they were comparing 2 exercise programs across the choice task. So they didn't ask people whether they would be willing to do exercise or not, which was something that we did. So I guess yeah, they had already sort of answered that question in the exercise modality question.
And you guys included this paper. You cited it in the introduction, didn't you? With that other systematic review?
Yeah, I'm fairly sure we did.
I think you did. So
It
there's
looks like they like cardiovascular training from that study that Giovanni just sent around.
and that's another thing when we talk about prevention of injuries with very heterogeneous exercise programs. You know, it's very hard to make comparisons where we say just general, well, it looks like just exercise or movement or just the process of getting out there and doing something has this positive effect, but it's hard to make inferences in regards to the mechanisms. Taylor Allen Flanick, do you want to unmute yourself and ask that question?
Hi. Taylor, actually, the other Taylor, answered it for me. And she said, they asked if they did 150 minutes of moderate intensity activity per week. Sorry, redundant.
And that was about 50% of the 647 people that met that guideline, right? And I don't know what other percentages there were, but is that correct? It seemed like half of them were meeting that guideline, but we don't know exactly what they were doing. Is that accurate? Yeah.
That's right. Yeah.
That was surprisingly high to me. Pretty
Yeah.
active population for sure.
Yeah, and that's a well-known problem with self-reported physical activity data. People usually overestimate what they do. So if you look at the objective measures of physical activity, they're always should tell a different story than this self-reported one. So yeah, it's probably something happening there in that regard.
Is that why you didn't include that in the characteristics?
Yeah.
Yeah. Is it? Okay.
Yeah.
Interesting. Because I was wondering if that would be a factor that had anything to do with it. But then as I was looking at the tables, I didn't see it again. But that makes sense.
How did you guys
Estimates
decide?
from who?
How did you guys decide on a price point for like, I think it was per month, it was like either 73 or 95. Was that based off of just kind of income median across the country, or how did you decide to place the price point there?
Jermaine, how did we dichotomize the cost?
Yeah,
the costing?
yeah.
It was only based on the median value of the variable. If I got your question right.
Well, you picked 200 as kind of the cap, right?
I think he's talking about how we define lower and high income. Isn't it?
Yeah, that's correct.
Yeah. Yeah, if I'm not wrong, I think we did a median split. Can't remember off the top of my head right now. I'll look into that and I'll get back to you.
Yeah, it's based on self-reported income of 41,000 per year. And
yeah, I think this is kind of a threshold for lower income. I can't exactly remember why we got this, if it was based on this threshold or if it's just a median value, and then we just split the participants into two, dichotomize them into earning more or less. But I'll have a look.
Along the same vein, how did you guys come up with the figures for cost?
Yeah, there was also a pragmatic decision because there's not a lot of information about how much a exercise prevention program would cost here in the country and probably anywhere else either. So we kind of got values that were close to how much a physio session is billed for. And that, that's usually around $100. And so we got a smaller value, some values that would be what we thought would be within the range, the acceptable range, 100, 150, and 200, which would be a little bit pricey. in relation to what people are currently used to.
Okay, but we got a couple more questions, and then we'll dig into kind of the, I guess what we can take from this and maybe future directions, and then we'll break out. So Michael asked, when you guys were having the conversation before you gave them the questions, the education on back pain, he asked, was there any discussion regarding the verbiage of injury prevention versus risk reduction, kind of making a distinction between those two terms? And I think this is kind of it's the equivalent of an inside joke, because we often within our circles talk about the term risk reduction is probably more accurate, paints a better picture than injury prevention. But was that distinction made at all?
No, it wasn't done. I think I understand where this comes from. I think people usually associate injury prevention as 100% reduction in the risk of something happening. But if I'm preventing something, that something won't happen at all because I'm preventing it. Whereas when you talk about risk reduction, you're assuming that there will be a continuum of risk reduction that could be either 1% or 10% or 50 or 100. Yeah, I get that point, but no, we didn't think about that.
Well, and I would add, Michael, a lot of the injury prevention. So papers that show prevention of injuries are looking at the average. So when you take a cohort who's got a certain base rate of injury, and then you do something where something changes and you follow them and they have less injury, well, on the average, you have had some relative prevention of injury. But the problem is then when you try to whittle that down to the individual, that's where we run into the problems, because we can't prevent injury in that individual. What we're really talking about is on the average, group-based versus individual-based. So it's not wrong to say injury prevention if you are talking about the correct context. But for us as clinicians, when we're dealing with the individual, then it becomes a lot more dodgy. Okay, so Nicholas asked a question. Samantha says she has to run. It's getting late in the UK. Come on now. Come on. I'm just kidding. What, Giovanni, you're in Australia, right?
Yeah.
What time is it there for you?
1 o'clock.
In the afternoon? Oh, you're sitting
in the afternoon.
Late. Okay.
Yeah.
Nicholas asked, he asked, so if I understand correctly, there are no best exercise prescriptions / dosage that would decrease or that would increase adherence to the program and decrease likelihood of recurrence. I'll let you go ahead and take that.
I don't think we know that answer yet in the prevention literature. So similar to the treatment of back pain literature, where we have a whole bunch of different exercise approaches that provide similar effects. We probably have even less evidence in the prevention literature to say which modalities are effective. The way we've based our conclusions about effective programs for prevention is just by qualitatively looking at the characteristics of trials that have shown good effects, and by saying that they appear to be more intensive than the ones that haven't. But as for research on which modalities are the most effective, I don't think we have the answer. And I guess that's probably even more difficult for adherence, because everyone's going to have their own preferences for exercise. And from that study that Giovanni linked before, it seems that in that sample, at least cardiovascular exercise was the most preferred. But again, that might have just been in that sample.
And to be fair to you guys, that's not the answer. So the question that you were trying to answer with this paper is not what is the correct exercise dosage for adherence or for decreasing likelihood. It's what's their preference for exercising versus not exercising, what factors influence those preferences. But Nicholas, the systematic review that they link and that we've mentioned a couple of times in the introduction, talking about all of the different types of programs out there to prevent the recurrence of low back pain. It's nice. Those systematic reviews are nice because you can just pull the papers. You can, like, the protocols are in tables there for you, and then you can pull the papers to see, check the forest plot, see if there's any outlier studies, and say, oh, okay, let me pull that paper specifically and see what they did, see what the sample the cohort characteristics were, see what the exercise program was. But yeah, when we figure that out, we'll either be rich or very poor, because nobody will come to see us anymore, or we'll have found the answer. One of us will be rich in this group, and then everybody else will be poor.
Well, that's what I think was so valuable about this paper, right? Because we certainly don't have any evidence, at least that I would be strong, that I would say is strong, to suggest that there's one type or frequency or modality that's better than the other. So at the very least, we should probably identify barriers to just get people started on something, right? So that's what I thought was highly useful and practical about this paper, is just, why can't we just get people moving a little bit more? What are the barriers to entry there, and how can we address it? Because get them started at something, it's going to be better than nothing.
Ben says McGill Big Three and reverse hypers only, forever. Louis and Stu. James, do you want to unmute yourself and ask your question? Or are you going to make me read that? It's a good one.
I can do that.
Okay.
Yeah, so basically I was going through your eligibility criteria, and you included asymptomatics as well. And when I look at your mean pain intensity, it's pretty low and not a lot of sick leave in the last year. So do you think that this is acute and kind of mild low back pain? And do you think is that as important to know their exercise preferences as the people who would be like chronic low back pain?
Yeah, so that was a very good question, James. And when we included participants, we were looking for people, like I said, had an episode of back pain or were experiencing back pain at the time of the survey. Those people, the ones that had pain, that had an average pain of 5 something, which is quite similar to what we found in clinical trials and in primary care. But the people who had back pain, they had some very low levels of pain. Some of them still reported some pain, 1, 2 out of 10, but they considered themselves asymptomatic in the survey. And that's what brought the mean average of pain down to 4 something. But then we, in the mixed logit, in the main analysis, we sort of tested whether the different pain status would make a difference in people's preferences, and apparently it didn't. And that was something that was quite interesting for us too, because I think this hypothesis can go either way, right? Either you would be willing to buy into an exercise program because you're in pain, or because you're no longer in pain, but you don't want the pain to come back. But the reverse is also true, or could be true. You got rid of the pain, so you don't mind anymore. You know, it's a problem of the past, it's gone. And you're in pain right now and you're too afraid to exercise, so I'm not going to do that. And we found that the pain status didn't make a difference. And just in relation to your last comment about a sick leave, again, 30% is quite, I think it's quite similar with what we found in clinical trials and in back pain as well. About 1/3 of people have been off work over the past year. This is kind of a consistent number.
Kevin, do you have anything to add or ask before we break out?
No, I don't think so. That's all my notes I had.
Okay, cool. So yeah, Taylor asked what the authors think the biggest takeaway is from this, and I'm going to put that on pause because that's what I want you guys to talk about. When we come back and we can tie a bow on that, and they can Giovanni and Joshua can tell us the secrets to all things back pain. They've been saving it until the very, very end. So stay tuned. I'm going to put in a couple prompts. We're going to break out into groups. This is where we're going to lose half of you. Maybe you guys are more brave than last week. So I got 3 prompts that I just put into the chat, but as a whole, what we want you guys to discuss is what your main takeaways are from this. And I'm going to try to preempt you from leaving. Six breakout rooms, And we're off. I think everyone's back, or everyone that stuck around. Okay, and I pressed record again this time. I forgot that last time, so we're golden. Can you guys hear me? Give me a thumbs up if you can. Okay, cool. So Michelle asked a good question real quick before we get into some takeaways. She asked, do you think pain status would make a difference in exercise preferences in different countries or cultures? And I'd be interested to hear everyone's opinion on this. My short answer is yes. I think that does have an effect, and it can have an effect. And then there have been shown to be cultural differences in the pain experience and how they perceive and report pain. Giovanni, do you have any thoughts on that?
No, I agree with you completely.
So just, another factor to think about. But you Aussies aren't too much different from us in the States. You spell words, sometimes you add a letter, no big deal. Color, right, with a U. Just little weird stuff like that, but no judgment. So we'll go to Taylor's question. Takeaways from this, and that may even just be kind of rehashing the discussion in regards to future directions of research. But for clinicians, as they're going through this paper and considering the findings, what can we take away from this?
I guess in terms of research, the takeaways, it seems like we need more research on brief interventions that could potentially be effective. So I don't know if there's as much value in doing very intensive prevention programs or research on intensive programs, because at the moment, it seems like even if they are effective, they're probably not going to be acceptable to patients. So if we can find a way to make a brief intervention that's home-based, potentially targeted towards self-management, we can make one of those effective, then I think that'll be a big game changer in the prevention field.
I think there's also an issue about listening more carefully to what people in pain or patients tell you. So I think what our study showed is that people are keen to do exercise, and sometimes there would be enough for physios and for trainers to think that the patient is on board. But then if you keep asking some questions, if you keep digging into it, and if you ask whether they would be willing to undertake what you think is the best approach for them, would they be willing to do that, yes or no? And I think that's for me, that was a big takeaway of this study: understand people's preferences. And it's not only a yes or no question, you need to sort of dig more into it.
Kevin, what are your thoughts on that? Takeaways?
Yeah, I mean, I agree 100%. Like we talked about, it's in terms of specific forms or modalities of exercise, we probably don't have a lot of evidence to suggest one that's preferential to the other outside of some of the intensity stuff. So I think the next best thing we can probably do is just identify what people feel like are obstacles in getting them engaged in it to start with. And that's probably the best place we can go from there. Is we know that exercise, based off of the evidence that we have, and education is probably the best place for us to go to start with. So how can we design and build a program out for them that is going to, one, keep them consistent, and two, be manageable for them over the long term?
I would echo that. I think if anything, this gives us some ideas for questions to ask. And there's a lot of, we're talking about papers like this. Obviously, now we have to consider the person who's in front of us. And so if this is a person who legitimately gets in those exercise guidelines and enjoys all different types of exercise, these are questions that you can dig into. And if they're already like strength training, they like cardiovascular training, they like all these things, maybe they will be more apt to go for a longer program because that's what they've already been enjoying. But when you have somebody who is not doing those things currently and does not meet the guidelines and hasn't been physically active in 10 plus years, it's going to be probably a barrier if you give them a 4-day-a-week program right off the bat. So a lot of these things are common sense, but I think papers like this help us realize that there's a lot of nuance and there's a lot of moderating factors to take into account. And at minimum, I think it's a reminder of that, which is good. Anybody have from your breakouts have any thoughts on takeaways or inferences that you can make from this?
We didn't talk about this in the breakout, but I think something that was helpful is kind of this article seemed to introduce this idea that, all right, if we look at the entire population, we might not get much meaningful data, but if we can look at certain segments of the population and see trends within, then the clinical application of that would be asking yourself the question, like, where does the person in front of me fit relative to, my understanding of the literature? How does this person's demographic play out in the literature? And even something as simple as, socioeconomic factors, right? Like, I don't ask my patients how much money they make, but screening for that in some way, shape, or form is a really practical application that we know lower income is more of a barrier to continued exercise potentially, right? So I think just even being able to screen and ask maybe more thoughtful questions. Like, I one time made the comment to a patient at an eval, like, oh, do you have a spot at home where you can do this exercise? And he was like, no, I live in my car. I was like, oh, shoot, like, should have figured that out sooner here in the course of this eval. Just stuff like that.
Yeah, it's super important.
One more thing there, but then also I think that's a good counter to this idea of like, oh, care is individualized. We just throw evidence out the window because it doesn't capture the individual nuances. This is maybe giving us a means of starting to filter and get a little bit more meaningful or applicable data.
Yeah, group-based stats that's what you said. It's like a starting point. It's like a prior. And then as we learn more about the individual, then we update that prior and modify as we need to. But yeah, this is super helpful. And I just put a link in the chat for the self-efficacy scale, the self-efficacy for exercise scale that was used in this paper. And it's super simple. And there's a reference there for the validity and the reliability, but this is the actual scale itself. 9 questions, 0 to 10, not confident to very confident. Interesting. And I don't know, I've not used this scale, and I don't know if there are minimal detectable change values or minimal clinically important difference values or anything like that. But just a tool that if any of you guys are interested in, we talk about self-efficacy a lot, but we talk a whole lot less about actually how to measure it and if what we do has an effect, negative or positive. So just something to look into there. Anybody else want to chime in before we wrap up?
I would say first, thank you to everyone. And I would say it was really cool getting a lot of new research ideas as someone that's about a year out from looking at PhD programs. So thank you, Joshua, and thank you, Giovanni, and I appreciate that.
Heck yeah. And potentially a line of work that you can spin off of, or at least model. That's awesome. Taylor, is that promise pretty easy to tack on the, what is that you're referring to?
Yeah, so promise, there are 2 different ways you can administer it. One's the computer adaptive, which is super great, but the other one's a short form. I think it's 29 questions. It's a little bit more intuitive than your standard like OSWESTRI or LAFS or whatever. But it has like a physical function domain, pain interference, participation in social roles, sleep disturbance, fatigue. I'm probably missing something. But then you can also tack on a self-efficacy for pain management or something like that. And then it's really easy to just like total each category. And then there's a conversion table that gives you the t-score, and the t-score is standardized to 50 is the mean, standard deviation is 10, and half a standard deviation is typically considered meaningful change.
Oh,
So,
cool. Okay.
yeah, it's really great.
I'm gonna put a link. But yeah, thanks for sharing that.
Yeah, I think it's healthmeasures.net is where you can go find it.
I got it. I'll put it in there. Cool. Okay, awesome. Well, this was a good one. And thank you to Giovanni and Joshua for staying on and doing this with us. This was kind of a treat for us. We didn't know until pretty quick before the meeting that they were going to be able to hop on and do this for us. So I really appreciate that. And Megan just posted in the chat the post-meeting feedback form. So open that up before we close out so you don't lose it. And it's super easy, and it's how we make these better. It's why we started doing the breakout. The feedback from those forums are exactly why any change that's made in these meetings is from you guys. So thanks again. And thanks everyone for being here tonight. Kevin, Megan, and Taylor and everybody else who chimed in. We will see you next time. And if you're in the forum, make sure you're popping in different topics. So we've still got a few in the tank, but we need a couple more for the next week's vote, and then we'll get after it. All right, everyone. Till next time.